بسم الله الرحمن الرحيم. نبدأ المحاضرة الثالثة.
Injuries of the forearm and wrist. Fracture of the radius and ulna. Mechanism. The fall and outstretched hand may cause spinal fracture if there is a twisting force. Sometimes there is direct trauma to the forearm. It may cause a transverse fracture. The fracture is easily displaced because there is a strong muscle attached to the radius and the bones are displaced usually. There is marked swelling and there is possibility of muscular injury and compartment syndrome. Diagnosis is usually obvious, but the wrist and hand should be examined for the possibility of nerve and vascular injury. The treatment in children, fracture reduction, close reduction of a fracture radius and ulna can be done, and the fractures can be stable by putting the arm in 90-degree flexion of elbow and well-padded cast from the axilla to the head of the metacarpals to prevent rotation. If the fracture proximal to the pronator arteries insertion, the forearm held in supination. If it is distal, it held in neutral position. In adults, unless the fracture is undisplaced, usually over-reduction internal fixation is required. Complications, nerve injury is very common complication, especially in the posterior and osseous branch. Compartment syndrome, because the two bones with bleeding and edema formation may cause increase in the pressure inside the compartments and lead to compartment syndrome. Delayed union, non-union, and malunion is a common complication. And after surgery, after plate removal, there is possibility of the fracture. Fracture of a single forearm bone. Usually fracture of single bone, either radius or ulna, in the forearm is uncommon because usually it is associated with the injury of the upper or lower radial ulnar joints, because the intact bone will produce that injury. Usually ulnar fracture can be missed easily, so it is wise to re-X-ray or do after 1 or 2 weeks, or do multiple review if there is local tenderness over the ulna. In the X-ray, the fracture could be occur anywhere, the radius or ulna, and sometimes it may be caused by direct blow, so-called nightstick fracture, when somebody has been hit by a stick and you want to protect his face, so the stick will hit the ulna, causing the fracture. Treatment: isolated the fracture of ulna need to be reduced perfectly. Slight angulation is unacceptable because it will affect the pronation, supination. And it will affect the superior and inferior radio-ulnar, the distal, especially the distal radio-ulnar joint. So if there is no perfect reduction, internal fixation is accepted, choice. And isolated fracture of the radius, the radial fracture prone to rotatory displacement, and to achieve reduction, the forearm needs to be supinated in the upper third, the neutral position in the middle third, and pronated in the lower third. This is because of action of the pronator teres and pronator quadratus muscles. And the position is usually difficult to hold, so in most of the cases we need upper reduction and urgent fixation. Montigia fracture dislocation. Montigia is an Italian orthopedic doctor described this injury, fracture shaft of ulna associated with disruption of superior radio-ulnar joint and dislocation of radiocapitellar joint. This injury occurs due to fall on outstretched hand while the forearm in forced pronation position. The radial head usually dislocated forward and it will not point to the capitella. In the X-ray marked by the arrow, black arrow, the black arrow should point to the capitella, and here it is away from the capitella. It is dislocated. The head is dislocated. It is very important whenever you have a fracture of ulna to check for the elbow or possibility of dislocation of the radial head and disruption of superior radio-ulnar joint. This can be done by proper lateral view. Treatment, the secret of the treatment is to restore the length of the ulna. If we do that, the radial head will relocate it spontaneously. And this can be achieved by upper reduction internal fixation, especially in adults with rigid fixation. When we reduce and fix the ulna, the radial head will relocate it to its normal position spontaneously. And by checking for flexion and extension of the elbow, to check for the stability of the radial head. Complication: if there is unreduced head of radius, this will affect the flexion and rotation of the forearm. In children, no treatment is advised after the end of a growth, and then only if function is significantly impaired, in adult operative reduction or excision of the radial head may be needed. Galeazzi fracture dislocation of the radius. This is commoner than Montegia. In this condition, there is a fracture of the distal third of the radius and dislocation or subluxation of the distal radio-ulnar joint. In Galeazzi fracture, we can say this is more common than Montegia, and there is a prominence or tenderness over the lower end of the ulna, which is a striking feature. It is important also to test for the ulnar nerve lesion, which is very common. X-ray, the displaced fracture in the lower third of the radius is obvious. Check for the inferior radio-ulnar joint, which is marked by the red arrow for subluxation or dislocation. Treatment, just like Montegia, we have to restore the length of the radius in order for spontaneous reduction of the inferior radioulnar joint. In children, this can be done by close reduction, while in adults, over reduction internal fixation is advised. This is the most common of all fractures in older people because of postmenopausal osteoporosis. Usually the patient is an old woman who gives a history of falling on her outstretched hand. Special features with undisplaced fracture, usually there is pain and swelling. In displaced fracture, usually there will be a deformity, we call it dinner fork deformity. X-ray fracture at the cortical cancellous junction, about 2 centimeters from the breast, from the articular surface of the radius. Over the ulnar styloid is fracture. Characteristically, the distal fragment is shifted and tilted both dorsally and toward the radial side. Sometimes the fracture is comminuted. Treatment in undisplaced fracture, usually the fracture can be held in dorsal suppling for 1 to 2 days, and then we change it to the cast for 4 weeks and starting to do immobilization as early as possible. Displaced fracture. In displaced fracture, we have to reduce the fracture first, and this is by either general anesthesia or local anesthesia by pulse block, and then by doing the reduction by gripping the hand, and traction is applied in the length of the bone to disimpact the fragments. The distal fragment is then pushed into place by pressing on the dorsum while manipulating the wrist into moderate flexion with ulnar deviation and pronation. The position is checked by the X-ray. If it is satisfactory, we put a slab posteriorly and we keep the wrist in flexion, ulnar deviation 20 degrees for each direction. The arm is elevated for 1 to 2 days so that the edema will be subsides, and recheck the patient after 10 days, and usually and after 2 weeks we can do manipulation if there is a satisfactory reduction. The fracture usually here within 4 to 5 weeks. Physiotherapy should be started as quickly as possible. In comminuted or unstable COLLES fracture, usually surgery is advised by putting K-wire or using an external fixator by a process called ligamental taxis. Complication, circulatory impairment. In this condition, we have to remove the bandage and we check for the circulation. Nerve injury, especially the median nerve. Malunion, to a certain degree, it may be accepted if it is not affecting the function of the wrist joint. Associated radioulnar and carpal injuries because of the injury to the bone does not exclude an injury to the soft tissue, and usually the trauma that causing injury of the bone causing an injury for the soft tissue. Tendon rupture, usually the extensor, the pollicis longus tendon may be ruptured after 4 to 5 months after injury. And joint stiffness is a common complication, and one of the most important complications is complex regional pain syndrome. In this condition, the early sign is swelling and redness of the finger joint. One, not to neglect the delay daily exercise. It is very important to do an exercise. Whenever the pain subsides, we have to do an exercise for the fingers. By the time the plaster has been removed, the hand is stiff and painful, and they are sign of vasomotor instability. X-rays show osteoporosis and an increase in the activity of bone scan. Treatment, physiotherapy, extensive course of physiotherapy. Smith fracture, this is the reverse of Colles fracture. The distal fragment is displaced and tilted anteriorly. So the cause is fall on the back of the hand. Treatment is to reduce by traction and extension of the wrist. The forearm can be immobilized in cast for 6 weeks. If the fracture is unstable, there is a possibility of internal fixation. This is a fracture, a transverse fracture at the base of the standard process of the radius due to fall on outstretched hand. Sometimes it's called chauffeur fracture. As you can see, if the fracture is not displaced, it can be treated conservatively, but the fracture passing to the joint, so it is an intra-articular fracture and maybe need for surgery. BARTON'S fracture subluxation. This is an oblique fracture from the surface, articular surface of the radius. The fracture line will pass either toward the volar side of the radius or toward the dorsal side of the radius. And this will produce two types of Barton fractures, volar Barton and dorsal Barton fracture. When there is the displacement of the radial segment will carry with it the carbon bonds, and so there will be subluxation of the wrist joint. Treatment reduction is easy, but the maintenance of reduction is very difficult, so upper reduction internal fixation usually advised. Comminuted intra-articular fracture in young adult. This is a high energy injury causing comminution in the intra-articular surface of the radius and sometimes ulna. The result usually in loss of joint congruity. The treatment, usually the simple option is to manipulation of the cast and immobilization if perfect reduction is achieved and maintenance of reduction can be sure. But because of the high comminution, usually internal fixation may be required. Simplest way by distraction and using of external fixator, and we have to follow the patient with CT scan in order to see the future and of the patient and to detect the complication, which are the carpal instability and secondary osteoarthritis. Distal forearm fracture in children. This is a very common site for childhood fracture. The break may occur through the distal radial phases or metaphases of one or both bones. Metaphyseal fracture usually incomplete or green stick fracture. The usual injury is a fall on outstretched hand, and the distal fragment will be tilted backward and toward the radial side, giving the dinner fork deformity and sometimes called juvenile Colles fracture. In metaphyseal fractures, sometimes there is only a buckle of the metaphysis cortex, small elevation in the metaphysis of the bone appear, which we call it torse fracture. Special feature, there is a pain and the swelling, sometimes dinner fork deformity appear. X-ray, when physeal fracture occurs, usually it is type 1 or 2 Salter Harris. And the distal fragment shifted backward and toward the radial side. Metaphyseal injury appear as a buckle, the X-ray down on right side, the two arrows show the radius, just there's a small elevation in the cortex of the radius. This is indicate the site of torso fracture, and the ulna show a green stick fracture of one cortex only. In the middle X-ray below the middle, we see that is a trauma to the forearm. After 2 weeks, the X-ray show a reaction or callus formation, and it is labeled by what happened here. There is a green stick fracture which is not appear by the X-ray, and there is buckle fracture which have not been noticed. The upper left X-ray, labeled with golden arrows, show a classical juvenile Colles fracture with the fracture of the ulna. And treatment in physeal fracture, usually it is reduced under general anesthesia and immobilized in a cast with the elbow flexed to 90 degrees. In buckle fracture, usually does not need more than rest of the forearm for 2 weeks in a plaster. Green stick fracture usually reduced easily, but re-displaced in the cast. Some degree of angulation may be accepted. Up to 30 degrees in case of a child below age of 10 is accepted, and up to 15 degrees when the child over 10 years. If the deformity is bigger than that, the reduction should be done by using thermal pressure and immobilization at the cast, and follow up weekly for 6 weeks to check for the stability of reduction. Incomplete fracture sometimes can be difficult to reduce, especially if ulna is intact. The fracture is manipulated, like in Colles fracture, and reduction is checked by X-ray and full-length cast is applied. And after 1 week, we should follow the case. If re-displacement occurs, there is a place for percutaneous K-wire fixation. Complication, forearm swelling, which is with the possibility of compartment syndrome, and malunion, especially in children above age of 10. Deformity much as 30 degrees in children below 10 can be situated within 3 to 5 years, and should be carefully mentioned to the family. It is very important to remember that a trauma can cause fracture or injury to the carpal bones, also will cause an injury to the soft tissue and the ligaments between the carpal bones and the ligaments of the wrist joint. We have to remember that the alignment of the carpal bones. The carpal bones consist of two rows, proximal and distal rows, and the scaphoid actually connecting between these two rows. The X-ray in the left upper corner of the slide, you can see that the radius, the boundaries of radius are lined with yellow color, while the lunate with red color and the capitate with blue color. These three bones with the third metacarpal are arranged in a line. So the line that passes through the radius will pass through the lunate, through the capitate, and to the third metacarpal. Any of the bones deviated from this line, it indicates that this bone has been dislocated. Also, the scaphoid will form an angle of 45 degrees between the two bones, and there are two concepts: dorsal intercalating segmental instability and volar intercalating segmental instability. This indicates the position of the lunate, whether it is spaced dorsally or ventrally, according to the ligaments connected it that is injured. And this is a very complicated subject. Knowing the name is quite enough. And the management of this condition, the carpal instability, is very important because it will help in preventing future complications. Scaphoid fractures account for more than 75% of all carpal fractures. Mechanism of injury is fall on outstretched hand with wrist extended. The scaphoid located in between the two rows of the carpal bone, so it will suffer from a force that may cause it to fracture. The blood supply of the scaphoid diminished proximally, so that 1% of the distal third, 20% of middle third, and 40% of proximal third may result in avascular necrosis and non-union. Special feature, there may be a slight fullness in the anatomical snuff box, precisely located tenderness in the same place is an important diagnostic sign. The palpation of the proximal pole of the scaphoid and telescoping of the thumb base will initiate pain. If any of these positive signs, suspicion of fractured scaphoid should be high. X-ray, often anteroposterior, lateral, and two oblique view, we call scaphoid view. Even then, the fracture sometimes will not appear. 2 weeks later, the break is usually much more clear. So, when there's a suspicion of a fractured scaphoid, it is wise to re-X-ray the patient after 2 weeks to see the fracture line. The fracture line is usually transverse through the narrow part of the bone, the waist. CT scan is more sensitive for diagnosis, but the MRI will give definitive diagnosis and to confirm or exclude the diagnosis of scaphoid fracture if the technique is available. So MRI can give a diagnosis in as early as immediately after the fracture. Treatment: if the X-ray looks normal but there is a clinical feature suggesting a scaphoid, the patient should be put in a glass holding position, plaster, that is the wrist slightly extended and the thumb abducted in abduction position, and the cast should incorporate the proximal phalanx of the thumb. This position called the glass holding position or scaphoid plaster for 2 weeks, and after 2 weeks we re-X-ray the patient. Another alternative method is by doing an MRI or CT scan. MRI is much better to identify the possibility of a fracture because we can diagnose it immediately. If the fracture is confirmed after 2 weeks, we should redo the plaster cast for further 8 weeks and then re-X-ray the patient and examining him. If there is union, it is enough. If it is not union, we can put the patient for another 4 weeks to diagnose, to maintain the position and to ensure of healing. After that, we can re-examine the patient, we examine the patient, and if healing occurs, that's all. If not, we may interfere. When the fracture is displaced, reduction is advised, but if we cannot assure proper reduction, we will go for surgery and internal fixation. Proximal bone fracture may need not more than a splintage. Complication: non-union, avascular necrosis, osteoarthritis. Fractures of the other carpal bones. Carpal fractures other than those of the scaphoid can be difficult to diagnose on the usual X-ray view. However, the diagnosis can be done by CT or MRI or by special X-ray view. And displaced fractures are usually treated by splintage until here. Displaced fracture will need open reduction and internal fixation. X-rays here show multiple fractures and it has been pointed by the arrows. Scapholunate dissociation. Sometimes sprain giving rise to persistent tenderness over the dorsum of the wrist joint, and this may show an X-ray as a gap between the scaphoid and the lunate bone. This pathognomonic feature with the shortening of the scaphoid indicate a scapholunate dissociation. Treatment: if the condition is diagnosed fewer than 4 weeks after injury, the bone should be repositioned by open reduction and held by K-wire. If it is late, we will think of joint fusion. Lunate and perilunate dislocation. A fall with the hand forced onto dorsiflexion may tear the tough ligaments that normally bind the carpal bones. The lunate usually remain attached to the radius, and the rest of the carpus is displaced backward. This is called perilunate dislocation. The lunate is still attached to the radius, but the other carpal bones are dislocated. Usually the hand immediately snaps forward again, but as it does so, the unit may be levered out of position by the displaced anteriorly, unit dislocation. So in order to get unit dislocation, first we have to have perilunate dislocation. And when the carpal bone return back to normal position, they will push the unit forward. Sometimes the scaphoid remain attached to the radius and it will be forced into a fracture through the scaphoid. This is called transscaphoid perilunate dislocation. Special feature, the wrist is painful and the swelling and held immobile. There is paresthesia and blurring sensation in the territory of the median nerve and weakness of palmar abduction of the thumb. X-ray anterior review is difficult. We can see only abnormal shape of the carpal bones, but the lateral view very informative and it's easy to distinguish lunate from perilunate dislocation. The dislocated lunate is tilted forward and is displaced in front of the radius, while carpal, cavitate, and metacarpal bones are in the line with the radius. With perilunate dislocation, the lunate is not displaced forward. Treatment. Closed reduction is first tried. If it is failed, we go for open reduction. Complication, usually avascular necrosis can occur, especially to the lunate bone. These are some X-rays. The picture, the X-ray number 1 show perilunate dislocation. The lunate bone is still attached to the radius while the perilunate bones are dislocated, the other carpal bones are dislocated, and anteriorly you can see that the lunate is in a normal shape and there is a wide separation between the lunate and the scaphoid. Treatment by fixating with the K-wires and sometimes erythrodesis is advised.
Thank you very much for listening. أكو أي أسئلة؟ طيب ناخذ استراحة 5 دقائق نكمل. عندنا محاضرة قصيرة جدا باقية لنا إن شاء الله. ناخذ استراحة 5 دقائق ونكمل بعدين. Okay, now we continue discussing the hand injury.
Hand injury. Hand injury. When we manage a hand injury, the function, the returning of perfect function of the hand has a special priority because the hand is a mobile structure. It has many movements, and any decrease in the range of the movement or loss of movement will impair the function of the hand severely. The examination of the hand injury include the degree of mutilation, the deformities that occur, arterial supply, nerve function, tendon function. Treatment of hand injury should be started immediately by splintage, and in this case we advise to put the patient in the position of circummobilization. That is, the wrist is extended 20 degrees, the thumb is abducted, and the metacarpophalangeal joint fixed up to 70 degrees, and proximal and distal interphalangeal joint are extended. This position will keep the ligaments tight, so and in longer distance. And so whenever there is adhesion, the possibility of rehabilitation to overcome the problem is quite high. So this is the position we keep the hand in to prevent the possibility of shrinkage of the ligaments and decrease the range of movement. We have to prevent swelling by elevation of the hand, and we have to start with rehabilitation as early as possible. Carpometacarpal dislocation, when there is dorsiflexion and longitudinal impact, especially in motorcyclists and boxers, this may cause carpometacarpal dislocation. And sometimes this problem associated with the fractures. And if it is difficult to diagnose by X-ray, CT scan is advisable. Treatment, closed reduction is a trial, and if it is failed, we go for open reduction and fixation with the K-rest. Fractured metacarpals. The metacarpals bones are vulnerable to load and fall upon the hand. The force of a boxer punch, the bones may fracture at the base, the shaft, and through the neck. And the mid-shaft angulation deformity is usually marked, and even if it is persistent, it does not interfere with the function. Rotational deformity, however, is serious and may result in malposition of the entire ray when the hand is closed in a fist. In the fracture of the neck, and particularly of the neck of the fifth metacarpal, the small distal fragment may be tilted markedly toward the palm. Special feature, if the fragment is not if the fragments are displaced, there may be a bump on the back of the hand or one of the ankles. Sharp of the metacarpal head are associated with punching injury. If the opponent teeth has punctured the skin over the metacarpal head and bite, then the joint will surely be infected. The X-ray, the fracture of the base of the metacarpal are usually impacted. Fracture of the shaft are either transverse or oblique, and there may be shortening or angulation of the fragments. Fracture of the metacarpal neck may result in forward tilting of the distal fragment. Treatment and displaced fracture need no more than a bandage for 2 to 3 weeks. Displaced fracture of the shaft, if there is both displacement or shortening of the bone, open reduction, internal fixation are required. Careful attention should be to correct the rotation deformity. Displaced fracture of the neck with the fracture of the metacarpal neck, angulation up to 50 degrees in the fourth and fifth metacarpal and 20 degrees in the second and third can be accepted. All other displaced metacarpal fractures should be reduced by traction and pressure. Reduction is maintained by a slab. If the reduction cannot be maintained, open reduction and internal fixation is acquired. Fracture of the head, close reduction can be treated non-operatively if fragments are and displaced. Displaced fragment like intra-articular fracture may need perfect reduction. complication, malunion, and stiffness. Bennett fracture subluxation. This is a fracture of the base of the thumb metacarpal with extension into the carpometacarpal joint. It is an unstable injury. The smaller fragment remain in contact with the trapezium while the metacarpal shaft is pulled proximally by the powerful abductor pollicis longus. The fracture dislocation is easily to be reduced by traction but difficult to maintain the position. And if it cannot be handled by plaster, overprotection internal fixation is advised. Complication, carpometacarpal joint may seriously damage subluxation, osteoarthritis may be occur. Treatment conservative, it is failed. We may go for erythrodesis or excision of the trapezium. Metacarpophalangeal dislocation, usually the thumb and fifth finger affected. Hyperextension forces may dislocate the phalanx backward and the volar capsule may be torn. If the metacarpal head had been forced like a bottom through a hole, close reduction would be impossible and the need for upper reduction is advised. Sometimes collateral ligament injury. For the dislocation, close reduction is attempted by pulling through the axis of the thumb and other finger and trying to levering the phalanx forward. If it is failed, the joint should be exposed and the reduction can be maintained by re-establishing the ligaments and K-wire, temporal K-wire. Torn ulnar collateral ligament of the thumb, metacarpophalangeal joint. This is a historical injury. We call it gamekeeper's injury, and nowadays it is due to fall on extended thumb in skiing or in sport. The ulnar side of the joint is swollen and very tender, and usually the case misdiagnosed as a sprain. X-ray should be done to exclude any fracture, and local anesthesia is then injected into the tissue along the inner adductor aspect of the joint, and the thumb should be suppressed in abduction while the thumb is with the metacarpophalangeal joint extended to, flexed to 30 degrees in order to see the ligament laxity of the joint. Ultrasound scan also can help to clarify the degree of injury. Treatment: partial tear can be treated by immobilization. Complete tear may need operative repair. Fracture phalanges. Phalanges fracture may result from direct trauma and therefore may be part of bone. Any part of the bone may be broken. Treatment: open wound should be treated carefully with debridement and careful suturing of the wound. If undisplaced fracture, these need minimal splintage, body strapping by splint litigate with the another. Undisplaced fracture of the proximal and middle phalanx, the bone should be straightened under local anesthesia and careful of avoiding mal-rotation. And injured finger should be splinted. If it is not stable, we go for K-wire. Fracture of the distal phalanx are usually due to crushing injury, and we have to care for soft tissue fracture can be ignored.
Quiz. What is mallet finger? What is rugby jersey finger?
Open injuries of the hand. Open injuries ranged from clean cut to laceration, crushing, injection of foreign material, bone defect, and amputation. Clinical assessment. Examination must be gentle and precise. It should be carried in clean environment, and it must be repeated in operating theater when the patient is anesthetized. X-ray is obligatory, and they may show fracture or foreign wells. Skin damage is important, but you have to remember that even a tiny clean cut may conceal nerve or tendon injury. Circulation to the hand and fingers must be assessed. Sensation and motor activity are tested and the territory of each nerve. Tendons are examined with care. Note the posture of the hand and fingers. Comparison with the opposite hand may show that the normal postural tension in one or other finger is absent, suggesting a tendon injury. If patient allow it, active wrist and finger movement are assessed. Flexor digitorum profundus perform flexion of the distal interphalangeal joint and tested by stabilizing the proximal interphalangeal joint and asking the patient to flex the distal joint. Flexor digitorum superficialis act by flexing the proximal interphalangeal joint and tested by stabilizing the other fingers in full extension and asking the patient to perform flexion so that the flexor digitorum profundus has been abolished. Fracture is very important to assess. Treatment. Pre-operative care, the patient will need painkillers, and if the wound is contaminated, it should be rinsed with sterile saline, and antibiotics should be given as soon as possible. Prophylaxis against tetanus may also be needed. The wound is covered with sterile dressing and hand is lightly separated. You can see that this pre-operative care and management is the same of open fracture, same as open fracture. Then we will take the patient to the theater, and in the theater we will do a wound exploration by expanding the wound and checking all the contents of the hand, the tendons, the nerves, and circulation, and we will see if we can do repair of the tendons, the hands, tendons of the hands, the intrinsic muscles of the hand, nerves, and circulation. There are many details, surgical details in your book. They are not so important for you. Pre-operative care is important to know, and the other just for general knowledge. After surgery, we have to remember that we need post-operative rehabilitation in order to regain the function of the hand. Thank you very much.
شكرا جزيلا على حضوركم، شكرا على يعني مساهمة الطلاب اللي ساهموا ويانا، علي محسن، مصطفى، علي، مهند. أتمنى المرة الثانية يكون المشاركة أكثر. هواية معلومات ذكرت بالمحاضرات تسهل إن شاء الله بكل إعادة بعد ما نقرأ المحاضرات وبعد ما نناقش العملي، تسهل الكسور، تسهل بالتدريج. أنا معاكم ضد المادة، أنا مو ويا المادة ضدكم، دائما هذا الكلام أقوله، أنا معاكم حتى نفهم هذه المادة. أكو تفاصيل بالكتاب عن شغلات السيرجري، تفاصيل السيرجري هذه ما نحتاج نركز عليها. نشوفكم إن شاء الله الأسبوع القادم بالمحاضرات القادمة. إذا أكو سؤال تفضلوا، وإذا ماكو سؤال أخذوا راحتكم.